Bismillahirrahmanirrahim. Good day, everyone. I'm Dr. Mahmoud Sheikh. Today's session is titled KDIGO 2021 Clinical Practice Recommendations, the KDIGO Takeaway. Now, sometimes in our busy clinical practice or during exam preparation, we don't have time to go through every single detail of the guidelines, and that's perfectly fine, no problem. But because we are often need, in the essence, the takeaway, those practical and high yield points that help us apply evidence directly at the bedside or recall it effectively during exams. So, in this session, we'll do exactly that. We will walk through the key KDIGO guidelines, not in exhaustive depth, but in a way that lets you grab a bite-sized summary from each major topic. Think of it as your KDIGO quick access, concise and clear and clinically useful. By the end, you will have a full picture of the 2021 KDIGO framework and also the updates, but in a most practical and memorable way. Now let's move to the general principles of kidney biopsy, which remains the cornerstone of glomerular disease diagnosis. The kidney biopsy continues to be the gold standard. It gives us the histological clarity needed to initiate or adjust or even predict treatment outcomes of any patient. No other test provides the same depth of diagnostic precision. However, there are well defined situations where treatment can proceed without a biopsy. For instance, if we have a patient with post-plur antibody confirming membranous nephropathy in a patient with preserved kidney function, similarly, in a patient with positive ANCA serology, MPO or PR3 can confidently guide therapy in vasculitis. Classic presentation of anti-GBM disease, Fabry, or even Albert, especially with characteristic family histories, can also justify starting therapy without a tissue diagnosis. And of course, when biopsy is contraindicated due to bleeding risk, comorbidities, and or advanced disease, clinical judgment prevails. Finally, in cases like active lupus nephritis, where delaying therapy could worsen outcomes, treatment may begin empirically while diagnosis is refined later, or in case of RPGN. This balance between precision and pragmatism captures the spirit of KDIGO approach: use biopsy whenever possible or available, but never lets its absence delay life saving treatment. Supportive care is really the backbone of managing glomerular disease, while immunosuppression often takes the spotlight. These foundational measures are what truly determine long term outcomes and patients' quality of life. Let's start with managing edema and hypertension. Our first line approach combines an ACE inhibitor or ARBs with loop diuretics. Frequent monitoring is essential both for optimizing therapy and for preventing complications such as hypertension or worsening renal profile. Next, addressing metabolic and thrombotic risk. We maintain serum bicarbonate above 22 to control metabolic acidosis. Statins are recommended first line for hyperlipidemia, given their proven benefit in glomerular disease. And when albumin drops below 25 grams per liter, anticoagulation should be considered a full dose for thrombotic events and prophylactic when the risk is high. Finally, lifestyle synergy plays a powerful role, like weight control, regular physical activity, and heart healthy and moderate protein diet all contribute to renal protection. And one of simplest yet most effective interventions remain tobacco cessations, absolutely critical for slowing kidney disease progression. So the key takeaway here is that supportive care isn't secondary. You should start with it. It's the foundation upon which all disease-specific treatments stand. A holistic, well monitored approach is what truly promotes patient well being. IgA nephropathy remains one of the most common primary glomerular disease worldwide, and its diagnosis risk assessment continue to evolve with new evidence. Starting with diagnosis, the kidney biopsy remains the definitive gold standard. At present, we have no validated serum or urine biomarkers that can replace histological confirmation in IgA or even others GN patterns. Pathologically, we identify mesangial IgE deposits, often accompanied by neutrophilic infiltration. Clinically, suspicion is raised in a patient presenting with hematuria, proteinuria of unexplained cause, particularly in young adults. On the other side, risk assessment is now guided by the International IgE Nephropathy Prediction Tools, which integrates both clinical and pathological variables. The key risk factors include baseline CMG4 and degree of albuminuria, histological activities such as bipolar staining, and underlying genetic predispositions. As shown here, disease progression can be insidious. On average, 50% decline in CMG4 can occur within about 6.7 years if untreated or suboptimally managed. That's why early identification of high risk uh, patients and targeted interventions are absolutely crucial to change the trajectory of kidney function loss. In summary, biopsy provides the diagnosis, but risk stratification drives our management, bridging the pathology and prognosis and personalized therapy. Now that we discussed diagnosis and risk assessment, let's move on the management approach to IgA nephropathy. The KDIGO emphasizes an evidence-based integrated treatment algorithm where management is tailored to individual patient risk profiles guided by the International IgA nephropathy prediction tools. At the core of this algorithm is risk assessment, which determines how aggressively we can intervene in any patients. From there, treatment integrates three essential domains: supportive care, immunosuppression, and novel approaches. Let's start with supportive care. Dietary sodium restriction, loop diuretics for edema, and ACE inhibitors or ARBs for hypertension remains the foundation of therapy and is crucial for slowing progression in all risk categories. Moving to immunosuppression, this is reserved for high risk patients with resistant proteinuria or declining in kidney function despite optimized supportive measures. Here we use high dose steroids, glucocorticoid as a first line therapy, while cyclophosphamide may be used in severe or rapid progressive disease. For those who are steroid dependent or intolerant, rituximab is emerging as an alternative approach. Finally, we have novel approaches and existing in IgA nephropathy care. These include targeted therapy for refractory cases and ongoing research into biomarker driven treatment integration, which will help personalize management even further. In short, KDIGO version of IgA nephropathy is precision medicine in action, integrating traditional care, immunological control, and innovation therapy to improve long term renal outcomes. When discussing IgA nephropathy, it's essential to recognize that not all cases follow a slow or indolent course. The slides focus on aggressive variants where prompt recognition and early intense therapy can make the difference between recovery or reversible kidney or residual renal failure. Let's start with a rapid progressive course of IgA nephropathy. These patients show a quick decline in kidney function, sometimes reaching end stage renal disease within months to few years. They require immediate nephrology referral and aggressive immunosuppression, often high dose steroids, and in severe cases, plasma exchange should be considered. Moving to crescentic disease, this variant is defined by the presence of prominent glomerular crescent on biopsy, reflecting severe inflammatory injury. Management here involves high dose steroids combined with CNI or MMF, and many patients benefit from plasma exchange. Because relapse and chronic progression are common, long-term immunosuppression is often required. Finally, IgA vasculitis nephritis or IgA VN represents the overlap between IgA vasculitis and GN. These cases need an integrated management approach targeting both the vasculitic and nephritic components, often through combined immunosuppressive therapy. The key takeaway is simple but vital. Early recognition and aggressive intervention are critical. These are patients where timing truly determines outcomes. Delay means irreversible scarring, but early decisive treatment can preserve kidney function in any patient. Membranous nephropathy remains one of the most common causes of nephrotic syndrome in adults, and over the past decade, PLAR2 antibody testing has completely transformed our diagnostic approach. The process usually begins with the patient presenting with nephrotic syndrome. That's our clinical starting point. Next, we move to serum PLAR antibody testing, which now serves as a central diagnostic step. If the result is positive, that alone is sufficient to confirm PLAR-associated membranous nephropathy, allowing us to begin treatment without the need of biopsy in many cases. However, if the test is negative, we can't stop there. These patients still require a kidney biopsy with PLAR2 staining, since early disease may not yet show circulating antibodies. Now, few clinical peers are worth highlighting. First, this approach helps avoid unnecessary biopsies, speeding the diagnosis and management. Second, negative test doesn't rule out PLAR2 associated disease in early stages, so clinical judgment remains essential. And third, timely diagnosis matters. Identifying PLAR2 associated membranous early not only improves outcomes but also reducing the risk of progression to chronic pattern. So, in the essence, the PLAR2 diagnostic algorithm has brought precision, efficiency, and safety to what was once a biopsy dependent diagnosis, a perfect example of how serological tools can replace glomerular disease management. In members nephropathy, management is no longer one size fits all, as we mentioned many times. The cornerstone of therapy today is risk-based stratification, which determines not only who should receive immunosuppression, but also when and how aggressively we should intervene. The KDIGO 2021 framework classifies patients into low, moderate, high, and very high risk categories based on combination of clinical and laboratory parameters. The main determinants include change in serum creatinine, which reflect renal function decline or degree of proteinuria as a strong predictor of progression, serum albumin levels indicating severity of nephrotic syndrome, and also a risk of thromboembolic events. PLAR2 antibody titers, which correlate closely with immunological activity and treatment response and prognosis of any patient. Now, looking at treatment strategy in the center of the slide, low risk patient can often be managed conservative with wait and see approach and supportive care. Moderate risk patients may benefit from agents such as rituximab, CNIs, and with or without low dose steroids. High-risk patients typically require rituximab cyclophosphamide-based regimens combined with steroids also. And for those at very high risk, cyclophosphamide plus glucocorticoids remain the standard of care to achieve durable remission and protect the kidney function. So, in summary, for this slides, risk stratification personalized therapy. It allows us to balance efficacy and safety, avoiding overtreatment or undertreatment in any cases, in mild or severe cases, and ensuring timely aggressive management for those at greatest risk of progression. Now that we have covered diagnosis and risk-based treatment, let's learn an equally important aspect: monitoring and treatment resistance in membranous cases. Effectively, management doesn't end with initiating therapy. It depends on how closely and intelligently we monitor the patient's response. We start with distinction between immunological and the clinical response. It's essential to remember that changes in PLAR antibody levels typically occurs months before clinical improvement. We mentioned this in previous lecture. So falling antibody titer is our early sign that therapy is working even before proteinuria begins to decline. Very important point in management in any cases to avoid over treatment or shifting to another modality agent of immunological therapy. Next, we emphasize early treatment evaluation by regularly checking PLAR antibody titers, even treatment initiation after we start the treatment, we can detect early non-responders and make timely adjustment rather than waiting for clinical deterioration of any case. And of course, comprehensive monitoring remains crucial. Combining antibody levels with proteinuria and serum albumin gives full pictures of disease activity and recovery. Now, what about patients who don't respond? Treatment resistance is defined as the lack of clinical improvement after several lines of appropriate therapy. These patients should be referred to expert centers where advanced or combination immunosuppressive options can be considered. We should also think about secondary causes. Persistent proteinuria despite immunological remission may signal secondary FSGS, which must be excluded. The clinical bottom line is that treatment resistance in membranous nephropathy often called for a shift in strategy, sometimes exploring alternative diagnosis, sometimes escalating therapy, but always guided by careful monitoring for both immunological and clinical markers. When it comes to minimal change disease, treatment success depends heavily on early initiation and proper duration of steroid therapy. The first line therapy for adults in high dose steroids started promptly to preserve kidney function and promote remission. As you can see in this timeline, treatment is divided into two key phases: the high dose phase and the tapering phase, spanning a total duration of about 24 weeks. Now, regarding duration limitations, the high dose phase should not exceed 16 weeks, and total exposure, including tapering, should stay within 24 weeks. Prolonging treatment beyond this increases the risk of adverse effects without improving outcomes. Once remission is achieved, we move into the tapering phase. Here, steroids are reduced gradually to maintain kidney stability, minimize relapse risk. The tapering should be slow and deliberate transition either to a maintenance dose or in certain cases to an alternative immunosuppressive therapy if needed. So the key message here is balance, um, enough duration for remission but not long enough to harm. Shortening unnecessary steroid exposure just as critical as starting treatment on time. Let's now move to FSGS, a podocytopathy with diverse presentation and significant therapeutic implications. FSGS is broadly categorized into primary FSGS and FSGS of undetermined cause, or FSGS-UC. This classification is essential because although we can appear similar to on biopsy, their underlying mechanism and treatment response are quite distinct. Primary FSGS typically presents with minimal change disease morphology, often characterized by diffuse podocytopathy and widespread foot processive effacement. Diagnosis is confirmed by kidney biopsy showing FSGS on a background resembling minimal change disease. The treatment approach relies on high dose steroids as a first line therapy, with many patients achieving remission, sometimes even spontaneous. In contrast to FSGS UC, has no specific morphological pattern and diagnosed is only by exclusion made after ruling out secondary causes such as obesity, drug exposure, viral infection, adaptive changes from hyperfiltration. These patients tend to have more aggressive course, often requiring additional immunosuppressive agents beyond steroids. So, from management standpoint, primary FSGS often responds well to steroids, while FSGS UC usually represent harder, more resistant treatment phenotype that demands an individualized, sometimes combination based strategy. The key takeaway is that accurate classification drives strategy because mislabeling as secondary or undetermined case as a primary can lead to unnecessary or potentially harmful immunosuppression. So it's a matter of balance in any case of FSGS. Now let's discuss the treatment algorithm for FSGS, which follows a structured stepwise approach beginning with steroids and escalating to immunosuppressive therapy in resistant cases. First line therapy remains high dose steroids. Patients are typically started on high dose oral steroids for up to 16 weeks. An initial short course of intravenous mesalprednisolone around 0.25 to zero point 0.5 grams per day for 1 or 3 days can be used to achieve rapid disease control. This followed by oral prednisolone dose of 0.6 to 1 milligram per kilogram per day, up to a maximum 80 mg daily. Once remission is achieved, the dose should be tapered gradually over several months to achieve maintenance phase. If patients fail to respond or relapse during tapering, we move to second line options, which include cyclophosphamide or rituximab and MMF, of which can be used in both primary FCS or FCS of undetermined cause. It's important to note that FSGS UC often requires more aggressive approach and longer treatment duration due to its resistance and relapsing nature. Therapy must always be tailored, balancing efficacy against toxicity and the patient overall risk profile. So, in summary, start with the steroids, evaluate a response early, and escalate rationally. This stepwise algorithm helps us target inflammatory process efficiently while minimizing unnecessary immunosuppressive therapy. When managing lupus nephritis, a single therapeutic target isn't enough. We need a comprehensive multidisciplinary approach that preserves kidney function while controlling systemic lupus activity. Let's start with the cornerstone. Early diagnosis is absolutely crucial for nephron preservation. Diagnosis confirmed by kidney biopsy and ongoing serial monitoring of kidney function and proteinuria helps detect disease activity early before irreversible kidney damage. Next, hydroxychloroquine. This is the one of the most powerful yet underutilized tool in our practice. It's universally recommended for all lupus nephritis patients unless contraindicated, and it serves as a first-line disease-modifying therapy. Its benefit extend beyond renal outcomes, improving survival, reducing flares, and even lowering thrombosis risk. Equally important is essential supportive care. This includes rouse blockade, meticulous blood pressure optimization, addressing secondary issues such as hyperlipidemia or anemia. These measures may sound basic, but they have a profound impact on long term renal preservation. Finally, we reach tailored immunotherapy. Here, the goal is personalization. Therapy is selected based on disease class, extrarenal involvement, and presence or absence of nephrotic features. Adjustments are made dynamically as disease evolves. In summary, lupus nephritis management is not a single drug decision. It's orchestrated plan combining early detection, supportive measurement, and hydroxychloroquine and precision immunotherapy. The most successful outcomes comes from vigilance, teamwork, and individualized therapy and care in these patients. When it comes to proliferative lupus nephritis, particularly class 3, class 4, class 3 or 4, a timely and well-structured therapy is critical to preserve kidney function, prevent irreversible scarring. Initial treatments build around three coordinated pillars. Steroids and immunosuppressive therapy and long-term maintenance. Let's begin with steroid. We typically start with intravenous muscle pulses around 0.25 to zero point 0.5 grams daily for 1 or 3 days to achieve rapid disease control. This is often followed by oral prednisone dosed at zero point 0.6 to 1 milligram per kilogram per day, not exceeding 80 mg per daily, and tapered gradually over several months to a maintenance level. The second element is immunosuppression therapy. The first line option for most patients is MMF, which has strong evidence supporting both efficacy and safety. As an alternative, especially in certain population or when MMF is not tolerated, we can use low-dose intravenous cyclophosphamide following the Euro-Lupus protocol. Once remission is achieved, we transition to maintenance therapy, and again, MMF remains a perfect agent, especially in female black patients. It should be continued for at least 36 months following induction with regular monitoring of kidney function and proteinuria to ensure stability and detect relapse early. The key clinical message here is personalization. Personalization, as we mentioned before, both treatment duration and intents must be tailored according to disease activity and extrarenal manifestations. Early initiation and careful monitoring remain our best tools to preserve long-term kidney survival in a proliferative lupus nephritis case. One of the greatest challenges we face in lupus nephritis is refractory disease. When patients fail to respond adequately despite standard induction and maintenance therapy, managing these cases requires a systematic stepwise approach aimed at identifying reversible factors and optimizing outcomes while minimizing toxicity. The first step is verifying medication adherence before labeling a patient as refractory. It's critical to confirm that therapy has been taken correctly and consistently, check plasma drug levels, infusion records, and ensure appropriate dosing. Non adherence is far more common than we think and can mimic treatment failure. If adherence is confirmed, the next consideration is to rebiopsy the patient. Repeat biopsy help differentiate between active inflammation and chronic irreversible damage. It can also uncover alternative diagnosis, for example, thrombotic microangiopathy or overlapping pathologies that require very different management. For patients with persistent disease activity, we then explore alternative regimens. This may include switching between MMF and cyclophosphamide-based protocols, or combining MMF with CNI or adding rituximab for selected antibody-driven cases. Finally, in truly resistant disease, we may escalate to advanced therapeutic options. These include extended intravenous pulse cyclophosphamide or enrollment in clinical trials evaluating novel biologicals management, or in rare situations, aggressive multi-organ, multi-agents immunosuppressive therapy under close supervision. The key takeaway here is precision. Our goal is to identify barriers to response and adapt therapy rather than reflexively increasing immunosuppressive. It's about protecting the news, but equally protecting the patient from unnecessary harm. The classification of MPGN or MPGN pattern has undergone a major transformation in recent years, moving from morphology-based terminology to a pathobiology-driven framework. Traditionally, we spoke about type 1 and type 2 and type 3 MPGN based solely on microscopic patterns, but this approach often grouped together very different diseases under the same heading. Today, the classification is mechanism focused, built around the underlying cause rather than the highlight finding in light microscopy appearance. This shift has been crucial because understanding why immune complexes or complement accumulates helps guide both prognosis and therapy. The modern classification recognizes three main categories. First, immunoglobulin mediated inflammation. This includes classic immune complex diseases like IgA nephropathy and lupus nephritis. These are characterized by immune deposits and may or may not involve complement activation. Second, we have the complement dominant group, which primarily refers to C3 glomerulopathy. Here, the defining features is predominant C3 deposition with a little or no immunoglobulin, reflecting dysregulation of the alternative complement pathway. Diagnosis in this group always require exclusion of secondary causes. And third is the immunofluorescence negative category, where no significant immune or complement deposits are identified. This often points to genetic, metabolic, or other immunological etiologies and mandate through available options to investigate a workup to uncover any root mechanism. In summary, the evolution from type 1 to 3 to this mechanism-based classification represents a paradigm shift, transforming MPGN from a morphological patterns into a set of distinct disease entities such as we mentioned, each with targeted diagnostic and therapeutic implications. C3 glomerulopathy is rare but severe complement-mediated glomerular disease defined by dominant deposition of complement component C3 in glomeruli, typically without significant immunoglobulin deposition. It represents a single category within complement-driven renal pathology, often overlapping with C3 glomerulonephritis and dense deposit disease spectrum. When it comes to diagnosis, exclusion is the key. We must first rule out infection-related GN, monoclonal gammopathy, and other secondary causes of complement activation. The hallmark remains isolate C3 deposition on immunofluorescence with minimal or absent immune complex staining. Because progression can be unpredictable, early nephrology referral is critical for timely management. Now let's move through the treatment algorithm. Step one is patient selection. Treatment usually indicates for those with proteinuria greater than 1 gram per day or declining kidney function over 6 weeks a month. Uh, Conservative management alone is sufficient in these cases. Step two, first line therapy typically involves combination of MMF and steroids. This aims to dampen immune-mediated complement activation and preserve renal function. If there inadequate response, we progress to second line options where eculizumab or anti-C5 monoclonal antibody has shown benefit in select patients with ongoing complement activation despite standard therapy. Finally, for third line cases, participation in clinical trials is encouraged as novel complement inhibitors targeting different levels of the cascade are currently under investigations. In summary, C3 glomerulopathy demands mechanism-based approach, balancing complement inhibition with immunosuppression, guided by careful histological and biomarkers monitoring, early identification, and individualized therapy remains our best tools to delay progression to chronic kidney disease. When managing glomerular disease, we must always adapt our strategy for special population, particularly pregnant individuals and pediatric patients. These groups require unique attention balancing disease control with safety for both mothers and child or for growing kidney and developing systems. Let's start with pregnant individuals. Before conception, preconception counseling is essential. It allows us to discuss disease stability, medication plans, and potential pregnancy related risk. Once pregnancy begins, immunosuppressive medication must be carefully titrated, choosing the safest option while maintaining disease remission. We also follow enhanced monitoring protocols with frequent kidney function testing and fetal surveillance to catch any complications early. For patients with lupus nephritis, it's vital to continue hydroxychloroquine, as we mentioned before, throughout pregnancy unless contraindicated. It reduced flare risk and improve outcomes without harming the fetus. Now, turning to the patient category, where management is equally nuanced. Accurate diagnosis relies on appropriate tools. For example, the first morning protein to creatinine ratio remains the preferred method for assessing proteinuria. Detailed genetic evaluation and family history help identifying hereditary nephropathy, as we mentioned before. In terms of therapy, children requires lower steroid dose for disease like minimal change disease and slower taper to minimize relapse and toxicity. Long-term management focus on monitoring um, growth and development observations, which is very vital for our pediatric population, ensuring that treatment doesn't compromise overall health. And finally, we emphasize transition planning, a structural process that moves adolescents smoothly into adult nephrology care, maintaining continuity and adherence across both groups. The guiding principle is communication and support. Involving families provide education that fits each developmental stage, ensuring that care remains patient centered every step of the way. As we look into the future, the 2021 KDIGO guidelines mark a fundamental shift in how we approach glomerular disease, moving away from one size fits all strategy toward truly personalized, precision based medicine. In the past, we often treat all patients within a disease category using the same protocol regardless of their risk, biomarkers, and response pattern. The era is coming to an end. Today, management is guided by risk stratification, tailoring the intensity and duration of therapy based on each patient individualized risk profile. This means lower risk patients can avoid unnecessary immunosuppression, while high risk patients receive timely and aggressive intervention. We also adopting dynamic treatment adjustment where therapy involved as a patient condition biomarkers change. It's no longer about static protocols. It's about adaptive and data-driven care. A key feature of this modern paradigm is precision targeting, using biological agents such as rituximab, other pathway-specific therapies to reduce dependence on high-dose steroids and their long-term toxicities. And equally transformative is biomarker integration, just like Plar antibodies in membranous or ankylosing vasculitis now inform not only diagnosis but also prognosis and therapeutic response, bringing us closer to precision nephrology than ever before. The benefits of these new models are profound: less toxicity for low risk patients and better, faster outcomes for those at high risk. It's shift from reaction to prediction, from uniformity to personalization, and it's redefining the future of glomerular disease. As we conclude, let's take a glimpse into future of glomerular disease management, future that being reshaped by technology and molecular science and data-driven medicine. The next decade will be defined by precision, prediction, and personalization, as we mentioned. And I attended many webinars in the last 6 months about the AI usage in such context. We are moving beyond conventional immunosuppression toward therapies designed for the individual patients, and this transformation is being fueled by four key innovations. First, AI integration. AI, as I mentioned, machine learning are no longer science fiction. They are beginning to powerful predictive models that can anticipate disease flares, optimize immunosuppressive dosing, and personalize treatment algorithms. These tools will help clinicians make faster, more accurate, and patient-specific decisions than ever before. Second, novel biomarkers. We are witnessing a surge in the discovery of new biomarkers that allow earlier diagnosis and more precise disease characterization. These molecular fingerprints are helping us move from symptom-based management to biological guided therapy. And third one is molecular targets. Advances in molecular nephrology are revealing new therapeutic pathways that promise more specific and effective treatment, reducing our dependence on steroids and broad spectrum immunosuppression. This is target medicine and it's at its finest, aiming not just to suppress inflammation but to correct the underlying molecular dysfunction. And finally, precision medicine, the unifying vision. Our approach is evolving from one size fits all, as we mentioned, to risk stratified, dynamic, adjusted care, guiding by continuous feedback from biomarkers, genetics, and patient exposure. The message is very clear in this context. Uh, Thank you for all for staying with me through this session. Truly hope you found it helpful and thought provoking. Remember, the goal isn't to fully grasp every single detail in one sitting. That's never how deep understanding works. It's about consistency, revisiting, reflecting, and connecting the pieces over time like a puzzle. With that steady approach, every topic becomes clearer and more meaningful. I appreciate your time and attention, and I look forward to seeing you in the next lecture. Thank you so much.